Good morning, everyone. Just really delighted to be a part of this conversation. I'm Sarah Scholle. I'm a vice president at the National Committee for Quality Assurance. We're not for profit in DC. We develop and maintain the HEDIS measure set and accredit health plans and recognize practices for high quality. I am actually representing a lot of the work that's been done by one of our a fellow who is now a full-time employee, Carrie Christensen, and she had to be in Berlin, so I got to do this instead. So let's see. What I'd like to do today is just focus some attention on how social determinants of health can be addressed in the quality measurement enterprise. And we've been looking at this from a couple of different perspectives. One, trying to understand how we think about what are the social risk items and how they get measured, and then how do we encourage organizations to address these issues in practice, and next, how do we account for social risk in our quality measurement and reporting. So I'll just touch on really quickly a few of the things that we're doing. So our work is really deriving from the National Academy of Medicine framework for how to think about social risk factors and performance indicators in value-based payment. So that is the conceptual framework we're using to try to think about what social risk is, and I know it's not the same as social determinants of health, but that's the word, how we're thinking about it. So one of the things we did first, Carrie did in her fellow work, was to do a review of how existing programs are collecting data on social risk. And the bottom line story is it's all over the map. And that's really a problem for quality measurement because all the words are different. We found that the programs had reviewed different kinds of categories. The most common ones were housing, food insecurity. Things that are in the National Academy of Medicine framework are not addressed, like social status, discrimination. But the biggest issue is even when we say something like socioeconomic position or food insecurity, we mean different things. And it's been operationalized in different kinds of data elements. And then when we look at the tools that are being used, they're asking very different questions. So that's a problem for quality measurement when we're trying to make apples to apples comparisons. And so the coding systems, I'm delighted to hear about this work on coding systems. I think it could really move the field forward. The Accountable Health Communities work that CMS is sponsoring could also help to drive attention to specific factors. We actually, in our programs for primary care practices, our patient-centered medical home practice, we have about 20% of practicing primary care clinicians who are recognized by NCQA. And we have asked them to think about social risk in their in how they deliver high-quality primary care. And these are data from our 2014 standards. We've just released a new set of standards that are kind of up the ante. But when we looked at what practices are doing, we found that most practices are doing a comprehensive risk assessment where they address issues around social risk. And but we were a little bit disappointed to find out what types of things they considered social risk. Easy stuff like family household composition, nutrition, household risk factors, not as much in some of the areas that have been addressed in these programs. And what we found was that when they addressed them, they did the assessment, we expect them to have some approach to making referrals and then tracking that information back. And then importantly, I'll just highlight one issue. So they're providing a community resource list. So if they identify people that have a food insecurity need, then they're providing a community resource list. But one of the things we want them to do is say, is that really working? Are people actually getting help they need? And that's where we find only 40% of recognized practices are doing that. So that's a harder thing to do. And as we have upped the ante in our 2017 standards, we're looking for more of this. And I'll just have to say, I participated, we always have a multi-stakeholder process where we ask people what should be in our standards and what should not. There was a huge debate. There were people who said, addressing social risk, that is part of primary care. And then there was another group of people who said, not my job. And when we look at the data from the 2014 standards, we find community health clinics do this, right? But private practices actually did pretty well, but not so much the practices associated with health systems. Okay, so another piece of Carrie's fellowship project was to try to understand how is patient-reported social risk related to social risk that we can estimate from neighborhood of residents, and how would this have an impact on how we think about quality measurement? Well, what we found is, and this is data, brand new data, where we compared, where we had information on the patient-reported data, and we compared it to neighborhood income based on the American Community Survey. And I just want to focus on the top row, where we see this is a household. These are individuals from a neighborhood where the average income is over $95,000. And even in that group, we find that about 12% of people, 13% of people are saying, I have a need for, I think this is housing or food insecurity. Okay, so we know that neighborhood data is not good enough to identify the individuals who need help, right? So that's different. Those are different ideas. But actually, we're also looking at how this is related to outcomes. And actually, the biggest predictors of outcomes like readmissions or hospitalizations are individual clinical factors. And the neighborhood data add a little bit, but if you add this on top, it's not adding that much. So it's really a question of we need information in different places for different purposes. So another piece of work that we're doing at NCQA is we do quality measures. We develop the measures for the Medicare Advantage program for CMS. And one of the issues they brought to us is to say, how should we account for socioeconomic status in HEDIS measures that are used for, for payment, right? They go into the STARS program, the payment program for Medicare Advantage plans. And so they asked us to look at the impact of these socioeconomic status measures that are available from the Medicare beneficiary files, right? There's not much data on social determinants that you actually have, that you know about Medicare beneficiaries. But these variables, whether there's a low-income subsidy, whether they get subsidies for their copays, dual eligibility for Medicare and Medicaid, or disability status. So they asked us to think about how you would address that in quality measurement. And so we looked at several measures. You can see this set of measures. We conducted a literature review. We looked to see whether socioeconomic status adjustment affected how plans get ranked on these quality measures, whether clinical covariates accounted for those effects, and whether the rates were correlated before and after adjustment. And our findings really led us to suggest that there are 4 measures where socioeconomic status has a negative effect on performance: breast cancer screening, colorectal cancer screening, diabetes care, the eye exam part, and all-cause readmissions. And so the recommendations are not to, so we don't adjust for these factors in the payment. And the reason for this comes out of the ASPE recommendation that really this is not a place to say we're going to make you whole because we're going to, I think of it as hiding the social risk in your performance score, but rather the recommendation is to account for it in the payment arrangement. And so right now we're working to figure out the best method for stratifying the data and presenting that, because by stratifying the reporting, that's where we highlight this and say, go work on this, rather than making it part of the adjustment. So that's my discussion. So basically, we're seeing a lot of variation in how people address social risk. That makes it really hard for measurement. We see that the data that we get directly from patients is different from what we might conclude for neighborhood data. And the challenge, we still have a lot of challenges in trying to think about how we account for social risk in our quality measurement and reporting. And it's going to be a challenge to think about how we move this out and make it a focus to try to improve care for people who have these needs. So thank you.